There's only one articular facet. Ribs 11 and 12 have no neck or tubercle. Because those are your floaters. Down the ball. And this is what that junction looks like. So we've got an articular facet here, and then it articulates both with T6 and 7. So it's connecting in with 3 points of contact of bony landmarks, to 3 unique bony landmark contact points, which helps with that stability, not only with the ribs themselves, but also with the vertebra, the kyphotic curvature in there as well. So we're really anchoring in that thoracic cage. And then ligaments, then there's a lot more that helps stabilize this area. Anterior longitudinal, which we talked about, the radiate, which if we focus in right there, that area, the radiate ligaments kind of spread out and around those junction points of the ribs with the vertebral body. And then we have superior and lateral costotransverse, and then intra-articular. So I mean, there's just a lot going on to help stabilize and make sure this region is going to stay anchored. And there's conversation about the gliding from the zygapophyseal as well as the rotation from the ribs. Lumbar spine. So lumbar spine gets cool. So we still have our same 5 components. We have the big, huge bodies down here. We've got the lamina, the pedicles, which go to our transverse process into our spinous process, which are a lot more shunted than what we saw up in the cervical. So they're big anchors and points. And the zygapophyseal joints, the articular surfaces here get to be more posteriorly facing, so they curve in a little bit. Face slightly anterior. What do we want to do? We want the wedge shape. Why do we have a wedge shape with these vertebral bodies? We mentioned this last time. Well, it's the function of the vertebral bodies being different from anterior to posterior. To make the what shape? That one? Yeah. I like that shape. It's a good shape. What is that shape?
Isn't that like the actual?
It's to do with the loading and the flexibility.
Okay, so what is it? Loading and flexibility? Not so much. What's the whoop shape that Jared so well articulated?
I have no idea what you're talking about.
Yeah, well, in the lumbar spine, right? So what kind of curvature do we have in the lumbar spine? We have lordotic, right? So we have lordosis down there. So it increases our lordotic curve.
Sorry.
There we go. We get it back. It tries to go default to UIW. That just doesn't work. So keep my spine back. I feel spineless now. Not too early for that. Seriously, dude, it's 10:50 in the morning. All right, so what do we have? Lumbar spine. We have. Oops, I'll hide you for a second. L5, L4, L3, L2, L1. So up at L1, it looks pretty squared off. The vertebral bodies from the anterior to posterior aspect really are fairly consistent and smooth. It doesn't change much. Now, as we get down to L3, L4, and L5, there we go, especially with L5, you can see, maybe now you can see, that it actually increases the width anteriorly. Now, if you look at the disc as well, it does the same concept. The anterior aspect is a bit fatter, swollen than the posterior. And that's increasing. It's actually creating that curve for us. It's giving us this because it's a little bit more anterior is creating an archway. Now the greater that arch, the less the stability. So we end up having some issues to where if the center of mass is pushing down through here, then that center line is actually going in front of, it's going in front of that junction of L5S1. To where that one right there has the potential to slip because it's not centered directly over my SI joint. It's not centered directly over my sacrum, sorry. So that gives us a good sense of instability. But we get a lot of that because we've got this increased need beyond the thoracic cage of having mobility within the lumbar. We've really got to find a way to balance those pieces out. Now the sacrum, S1, is inclined anteriorly, so it's actually facing forward to help catch that L5 and then turn it back into more of a kyphotic curve. And so that really, again, accentuates the problem we have with slippage of L5 over S1 most frequently. That slippage can sometimes be seen on L4, on L5. And then we talked last time how we can have sacralization or lumbarization in which L5 is actually fused into your sacrum or S1 is separate and a unique component. Now those are rarities that aren't going to impact so much of what we do with people, but it certainly would impact the stability if we're looking at them rehabilitation-wise later. Wow. Ligaments we've done. Somebody needs to stop adding files to my system and pay attention in class. Just saying, it kind of shows up in the middle of class. All right, so due to lordotic curvature in the lumbar spine, there's a decrease in static support and resistance to shear. So we have this shear force that can come off from L5 over S1. That then gets into discussions we've had before. Ligaments. Ligaments aren't always these isolated, unique bands of happiness. I mean, it's not like every little band of ligament is a unique structure. A lot of times it's just thickenings of a joint capsule. I'm going to guess and postulatize the reason that we've been fools for 100 years and have missed a ligament in the knee is kind of in the fact that it's built into the joint capsule that surrounds them as well. So we're identifying a common thickening within individuals that's not just something that's extracapsular. What we have in the lumbar spine is so amazingly intertwined and interconnected that it's very difficult to differentiate where the problems are, where they come from, and how to deal with them. So all of the ligaments that we have, again, they're not just, boom, a ligament that's definable and it stops. Many times those fibers will mix in with the muscle fibers, that mix in with the fascia on the superior surface. The structure and the support is so amazingly intermingled that if one thing gets hurt, it starts creating problems elsewhere. So the iliolumbar ligaments, we have 5 bands extending from the transverse processes of L4 and L5 to attach bilaterally on iliac crests. So it goes everywhere. Primary function is to protect L5 from anterior slippage. So if those relax or they get stretched by repeated abuse or lack of stabilization from core strength, then we're going to end up having those spondy cases to where L5 is slipping anteriorly. The thoracolumbar fascia, there's 3 layers of it, anterior, middle, and posterior, arising from the transverse and spinous processes, completely surrounds lumbar musculature. And then so the anterior is continuous quadrantal lumborum, and we'll get into the musculature in just a minute. And it blends with the intertransverse ligament. The middle layer isn't well defined, but it's continuous as well with the intertransverse ligament. It attaches the tips of the transverse processes. And the posterior layer, the most superficial layer, runs caudomedially, and the deep fibers run caudolateral. This covers the entire back, overshoots, it intertwines with the lats dorsi of the glute max as it goes over the pelvis, and then connects from there down. So we've discussed what do tight hamstrings do for us.
Knee problems?
What? Speak.
Knee problems?
Tight hamstrings?
No.
Potentially. But back problems. We have somebody who's exceptionally tight hamstrings. Where is the origin of the hamstring muscles? Ischial tuberosity. So if those hamstring muscles are super tight, then it's going to pull down on the pelvis. If it pulls down on the pelvis, then we have our back extensor musculature, which starts on the pelvis and the sacrum, and it's making them work over a longer distance. So if you put some physics in motion, I mean, if I'm resisting something here, that's fine, but if I make my arms work from the further out, that moment arm, that torque that's further out is going to increase the force significantly. And so if I'm making those lumbar back extensors work over a longer length, then we have a problem. It's going to fatigue, it's going to cause problems. So it's not just the musculature though, because built into the musculature is the surrounding fascia, the ligament to support on the deep ends and the fascia on the superficial ends. And now we actually have a shift or a pull on the fascia that's connected from the lumbar down through the pelvis, down to the hamstrings, and then we can actually go and have conversations about how that's interconnected with the fascia around the gastroc and the Achilles and its connection into the plantar fascia on the bottom of the foot.